Buenos dias a todos, gracias, and that's all the Spanish you're getting from me today. Unfortunately, although I am Brazilian, I'm South American, also my Spanish is not really good. So Oscar, he vetoed me. He said, no, not with that Spanish, not in our conference. But maybe if you invite me next year, I will study really hard, and my Spanish will be better. So I am an emergency physician, and I have double vision. Am I the only one? So I am an emergency physician. I am EM trained from Brazil, from one of the first residencies and from Brazil. And we're here today to talk about blood gas analysis. So to me, blood gas analysis resembles a little bit this. So if you're anything like me, you're looking at this picture and going, there's something going on there. So, but if we can have a better image. But if you analyze the picture, you're actually going to notice that these feet are small. There are, of course, 3 pairs of feet here. These feet are small. This one is very big, and this one is smaller. And the angle with which, they are like bumping, it doesn't seem like a sexual thing. Actually, maybe this is just a Sunday morning play with the kids and the wife. A husband just playing with her wife and the kids. It's very, very innocent. So when you get to analyze the blood gas, sometimes when you take apart the mess, you're able to see, well, this is not as bad as I thought. So I have no conflicts of interest. I get no money from pharmaceutical companies, although I would like to, wouldn't change my ethics, or maybe it would. And all the videos and images have been approved by the patients or their families for teaching purposes. So, I am an ED physician. I like simple things. We do have fun with complicated things, but that's not what I really like. I like simple things. So, the first thing we're going to talk about, what to do with the gases, is to take a picture. We're going to talk about what that means. And then we're going to make time for coffee. Who here doesn't like coffee? I have more coffee in my veins than actual blood. Find a real-life problem. Every time that I see someone give a lecture about this topic, always gets complicated. He goes on about tubular renal acidosis and those things that we never see in the ED. And of course, all you need is an excuse to intubate. I'm going to teach you how to get, from the blood gas analysis, a good excuse to intubate. So, let's get a little bit philosophical. This picture is from the tale of the 7 blind men. The first time this appeared seems to be in 1,000 years before Christ, a Buddhist text, and it tells us an important lesson. You have 7 blind men around an elephant, and each one of them is touching a different part of the elephant. If you ask one of them, what is an elephant? They're going to give you only part of the picture. So a blood gas analysis is always that. It's a metabolic snapshot, that moment in time, and it's always only a part of the picture. You have to use it to build the bigger picture of your patient's metabolic status. So let's get really, really basic here on the interpretation. The first actual high-yield information is the difference between acidemia and acidosis. When we say acidemia, we're talking about the result. We're talking about pH. But when we're talking about acidosis, it's a pathological process. So a patient with a normal pH can have 5 acidosis. So that's what we got to figure out when we look at the blood gas. What are the pathological processes, not just the pH? I would dare to say that it's not even the third most important thing in the blood gas analysis, the pH. And of course, alkalemia is different from alkalosis. So the patient can be vomiting, and when he vomits, he's excreting acid. So he's actually giving himself an alkalosis. The same patient can be with a profuse diarrhea and losing bicarbonate. So he is in acidosis. And if that process takes too much time, he's going to build up lactate, which is another acidosis. And all of this may be happening at the same time the patient is hyperventilating and giving himself an alkalosis. So you have to figure out what's happening to your patient, and the blood gas analysis is going to help you. So let's make time for coffee, because you gotta separate your sick patients. I've read this amazing line that says, emergency medicine is the science and art of finding the patients that are sicker than they look between the patients that are way better than they think. So when a few lab work, they have their own gravitational pull. It's like you're going in the ED and someone tells you, hey Dennis, I have a bicarb 2. It's like, what? You were going for coffee, but something, it pulls you to resolve that problem. You can't just leave it for later. So this patient, let's see, I thought it wouldn't be able to read it, so here we have a bicarb of 2.4. The normal bicarb is 24. So this is deep, deep metabolic acidosis. And the pH reveals it. It's 6.8, a deep acidemia. Some would say it's incompatible with life. Hope the video works. So when we got to this patient, and he was like this, he was talking. The audio is not working, and we asked him, sir, what is it that you're feeling? And he said, I'm thirsty. That's all. That's all he said, I'm thirsty. But when we saw that bicarbs, something bad is about to happen. It's like a train wreck that you're witnessing. It's going to crash, it's going to crash. A bicarb 2 should be seen by you like this. And this is what happened to him not long after. He got tired. His muscles are just not enough to keep washing the CO2 and maintaining a pH closer to physiology. If you noticed his eye, that was the ketamine. Yeah, I was about to intubate him, and before he was like this, when we tried to do a CPAP in him, he wouldn't let him. So we used ketamine and deleted sequence intubation in him. So, to get from the blood gas your sickest, actually look first at the bicarbonate. It's going to give you a high yield. If that's normal, look at the PCO2, and then look at the anion gap. Of course you're going to look at the pH. I'm not going to talk about that. But you can have a normal bicarbonate, a normal PCO2, a normal pH, but if your anion gap is high, you have to do something about it. This expression, I think that it shouldn't exist anymore, anion gap. What the hell does this mean? It's just because biochemistries, radiologists, and pathologists are very lonely people. And they keep making up stuff, so they have fun. And this comes from a time in which you could measure the anions, the cations, the positives and the negatives in your blood easily. But lactate would take 2 days. So they came up with this. It's almost always lactate. And today, we can measure every one of the positive and negative things in the blood. So maybe we don't need this expression anymore. But our point of care analysis usually only gives us sodium, chloride, potassium, and the bicarbonate. You take the positive stuff minus the negative stuff. And this is the anion gap. If it's 10, you're okay. That's stuff that you didn't measure, no, but it's negative. And if it's over 10, it's probably lactate. Explain everything. That's the moment when you're going to, no, I'm going for coffee, because I know exactly what's happening to my patient. I'm okay. I can go for coffee now. So you look at the blood gas, and you explain exactly what's happening to the patient, so you can be, this patient we're going to find a real-life problem for her also. Look at the way she's breathing. Memorize that pattern. I haven't seen it in any publication, but this way of breathing is almost always when the patient is getting comatose. This means metabolic acidosis in my practice. And look at the vital signs. They are normal. Yeah, a little bit of a tachycardia, sinus tachycardia, doesn't mean anything. And it's worse to read. So let's get the numbers. A bicarb of 3.9 and a pH of 7. So let's find a real-life problem for this patient. In the very own blood gas analysis, we get it. You can see it, but it's a glucose of over 600. So this patient was later confirmed that she has a DKA by urinalysis. So these are the real-life acidotic metabolic acidosis that you're going to find in the ED, And every time you see a low bicarb, every time you see a high anion gap, you think about these fives, and you learn about these fives, because you're going to get a patient like with these. We've talked about rare diagnoses and things the emergency physician always has to think about, and that's great. But my approach to the blood gas analysis is this. When you find metabolic acidosis, think about real-life problems, and you can plot the patient's way out of them, out of each one of them, and then you can go for coffee. So, but what about the not so common stuff? You should have in your pocket, in your third hemisphere, which is called a smartphone, the third hemisphere. In your third hemisphere, you keep a list of these rare things. So it's like you look at it and you see, oh, ureteral diversion. I didn't remember this. And this patient, actually, he had a bladder cancer, and the surgeon took the ureter and put it in his gut. So this gives him metabolic acidosis. I didn't remember that. So this is what you should do. But trying to remember, trying to do a differential diagnosis over one lab work, it's just not a smart thing to do. So this patient, if you could hear the sound, you would hear sound of the alarms going off in the ventilator. And this is also from the ketamine. It was, I've seen rarely the side effect, but it happens. So this patient was a real bad asthmatic. He had been tubed a lot of times, actually. And he came in, and right after he was intubated, he got worse, which is classical it's a classic for the asthmatic and for the small pneumothorax. When you intubate the patient, he gets worse. You always think you did something wrong, but you have to expect this. So, in the blood gas analysis of the patient, we had a bicarb of 31, which doesn't explain his state. We had a PCO2 of 66. So when you see this, you're thinking, well, maybe he is a COPD. Maybe this is chronic. And how do I know if it's chronic? You can sit down and do calculations, but we in DD, we don't like doing math, We like eyeballing things. So here's my tip. You look at the pH. If you don't have anything metabolic, you look at your lactate, and you have no other explanation for a metabolic problem, and the patient is retaining CO2 so much that the pH got acidemia, then you're probably in an acute setting. But you can also use the standard bicarbonate. As you know, the machine, it doesn't measure bicarbonate. It does math. It measures pH, PCO2, and puts in that Henderson-Hasselbalch formula that none of us remember, and spits out the CO2. But in the acute setting, that doesn't work, because what's happening here is not the patient, he has bicarbonate. What's happening is his whole body is buffering his acidosis. So when you look at the standard bicarbonate that some blood gas analysis will give you, it is normal, actually. So what this means? This means that he doesn't have bicarbonate in the blood. He hasn't had time to do that. So it's not chronic. Do something about the ventilation of this patient because he's not being able to ventilate correctly because of the severe spasm in his muscles. So for the last one, I want to give you the feel of the evolution of the blood gas analysis. That a lot of times is going to give you a good excuse to intubate. So the patient was brought to me in arrest. He was coming from the wards, and the doctor that was bringing the patient, after we resuscitated him and was stabilizing, he tried to tell me what happened. He was on shift for 24 hours, and by 12:53, he took this blood gas because the patient has dyspnea. Okay, then, let's see it. We have a bicarbonate 26, nothing much. We have a PCO2 of 32. Actually, it's low. And a pH of 7.5. Well, this patient is clearly hyperventilating, and he has no metabolic problem. Why is he hyperventilating? Well, we have a lot of things to think about. He can be going to heart failure, and has water in his lungs. So that's why he's hyperventilating. He may be with fear. He may be in pain. I didn't know what was happening. But I did know about this blood gas analysis that he took almost 8 p.m. And when he came to me with this one, he said, I don't understand what happened. Because right after I took this blood gas, the patient crashed. But look, it's not that bad, right? You got a 28 pH, which is almost normal, and the standard is normal. You have a high PO2. Look, the PO2 here was lower. You have a higher PO2. And the PCO2 of 49. Come on, the pH is still normal. It's not that big a deal. Yes, but the evolution tells an important story. Here, the patient did not have oxygen, any oxygen. That was the first time he started getting dyspneic. So the improvement in PO2, and that's a great tip. Every time you collect the blood gas, write down how the patient was, if he was in CPAP, in the FiO2 he was doing at the time, because it's impossible to interpret it without this information. So here, he had a Venturi mask of 50%, and actually, this evolution means that he was getting tired. The colleague was right. If this was the first blood gas analysis, I wouldn't be too worried. But knowing about this evolution, that the patient in a few hours needed more oxygen and was actually retaining CO2, he was alkalemic, he was not anymore here. So this evolution should show you that you should intubate this patient right now, and he wouldn't have arrested. The patient was tired. So, in short, that's what I wanted to tell you. It's a picture. You take a snapshot. It's like an EKG, and you can repeat it every time. You do some saline, you repeat it. You do some stuff with the patient, you repeat it. And you separate the sickest patients very quickly. It makes time for coffee. You find a real-life problem, and if you can't fix it, you have a great excuse to intubate. Thank you all.